the cardiovascular system, as you all are aware, there are two parts: the cardiac physiology and the vascular system, the circulatory system. We have discussed various aspects of the cardiac physiology. Now we will see the circulatory system and the circulatory physiology. The blood vessels, their arrangements, the blood flow through various organs, blood pressure, regional circulations, and so on. Let's begin with the first part, and that's functional types of blood vessels. You know, already you have known this, the anatomical organization: aorta, the arteries, the arterioles, metarterioles, capillaries, leading to venules, veins, venae cavae, and right side of the heart. But there are functional types in which these blood vessels are categorized. Let's look at these functional types. What questions can be asked on this? For instance, the greatest resistance to the blood flow in the systemic circulation occurs in which segment of the circulation? And the options are arteries, arterioles, capillaries, venules. The answer is arterioles. Yes, they are called as resistance vessels. Or critical closing pressure is, and the options are 0 mm of Hg, 20 mm of Hg, 40 mm of Hg, 60 mm of Hg. Well, it's in the range of 20 mm of Hg. We will see that. Okay, so let's begin. The first functional type is called as Windkessel vessels. It's named after a toy, actually, Windkessel. And aorta and large arteries are called as Windkessel vessels because they show what is called as Windkessel effect. And it's something like this. When the left ventricle pumps the blood into the aorta, aorta distends with blood as the left ventricle went into systole. So blood was ejected out and aorta will distend with this blood. And as the left ventricle goes in diastole, the aorta will recoil back and push the blood forward. The potential energy stored in that blood will be converted into kinetic energy and the blood will be pushed forward, it will move. So that's the Windkessel effect. In fact, there was a question on this. If a plaster cast is applied to the aorta, if a plaster cast is applied to the aorta, what will be the effect? Increased systolic and increased diastolic pressure, or decreased systolic and decreased diastolic pressure, increased systolic but decreased diastolic, or decreased systolic, increased diastolic. So, you know, various options. Well, both pressures will increase. Systolic and diastolic pressures will increase if a tiny plaster cast is applied to this. And therefore, what was the principle that was asked in the question? The Windkessel effect. That Windkessel effect will be minimized if a cast is applied, or even in the cases of atherosclerosis. Okay, so let's just understand once again. When left ventricle goes in systole, it ejects the blood and aorta will distend and accommodate the blood without allowing much rise of pressure. Look, try to understand. The pressure in the aorta will rise. It will become a systolic pressure. But there won't be a much rise of pressure because aorta distends and accommodates that blood. Okay. In the absence of that effect, if the aorta is not able to distend, then the pressure rise will be much greater. That is what happens in the conditions of stiffening of the vessel wall or atherosclerosis. And the second part of that effect is, here the left ventricle goes in diastole. That time aorta will recoil back and push the blood forward. So these are the two parts of Windkessel effect, and aorta and arteries show this effect, and that's how the blood is pushed forward, it circulates. Second type of blood vessel is resistance vessels. Resistance vessels which offer resistance to the blood flow. And what are those resistance vessels? Arterioles. So please remember, much of the resistance to the blood flow is offered by the arterioles in the case of systemic circulation. Whereas in the case of pulmonary circulation, 40% resistance is offered by the capillaries. So let's make it clear. In the systemic circulation, resistance, much of the resistance to the blood flow comes from arterioles, and capillaries, systemic capillaries do not offer much resistance. Whereas in the case of pulmonary circulation, capillaries offer almost half of the total resistance to the blood flow. Why is that in the pulmonary circulation? It's because capillaries are surrounded by the alveoli. Alveoli tend to distend and compress the capillaries, and therefore there would be resistance to the blood flow. But that's not the case here. In the case of systemic circulation, what happens is capillaries are in the tissue, and capillaries have a great surface area or cross-sectional area, I would say, cross-sectional area, and therefore the blood divides. So you see, aorta has got a large diameter and capillaries have got a great cross-sectional area, so that the blood divides and there is not much of a resistance. Where is the most of resistance coming from? It's the arterioles, because arterioles are relatively narrower and stiffer. Compared to the aorta and arteries, the arterioles are narrower and stiffer. So if you see, greatest resistance is offered, and therefore greatest drop of pressure in the circulation also occurs in the arteriolar segment. Let's have a diagrammatic representation to understand this particular point, how the pressure drops maximally in the arteriolar segment. In fact, there was a question like this before we take this particular diagram. The question was, in the recumbent posture, in which of the following segments there would be greatest pressure difference? I mean, segments of circulation will be given, and you have to mark which of them will have greatest pressure difference between point A and point B. So take options: saphenous vein to right side of the heart, femoral artery to femoral vein, right side of the heart to the cerebral vessels, and right side of the heart to the pulmonary capillaries or pulmonary vein. In which segment there will be greatest pressure difference? The answer was femoral artery to femoral vein. And why is that? Here it comes, the answer. Look, when the left ventricle goes in systole, its pressure peaks to about 120 to 130 mm of Hg. Then aorta and arteries, mean pressure in the arteries would be about 100. You see that there would be a pressure drop, okay, in the vascular tree, and that delta P, that is P1 minus P2, will drive the circulation. Let's see the pressure drop. So here is the arterial pressure, mean pressure, okay, arteries. Then now watch this. At the start of the arterioles, the pressure is 80 mm of Hg. This is only a representative diagram to just understand the things. So at the start of the arterioles, the pressure is 80 mm of Hg. Then end of arterioles and start of the capillaries, the pressure is 30 mm of Hg. Start of the capillaries, end of the arterioles and start of capillaries, the pressure is 30 mm of Hg. Then end of the capillaries and start of veins, the pressure is 10 mm of Hg. This is the capillary segment and that's the pressure change. So start of the veins 10 mm of Hg, and from there to the right side of the heart, right atrium, the pressure will be 0 mm of Hg, from 10 to 0, 0 to 2 mm of Hg or 0 to 5 centimeters of water. We have seen this in JVP. That's the pressure. But you can see these pressures in the circulatory system. The first point that you should note, I'm going to describe 2-3 things in this diagram. So first thing that you should note is that the greatest pressure drop has occurred in which segment? Arteriolar segment. See, at the start of arterioles 80 and by the end of the arterioles 30, 50 mm of Hg dropped. So this is the resistance segment, or arterioles are called as the resistance vessels. They offer greatest resistance to the blood flow and greatest drop of pressure occurs in the arteriolar segment. That's the first point which you must understand. Now second point is, look, at the start of the capillaries the pressure is 30 and end of the capillaries pressure is 10. So average capillary pressure is 15 mm of Hg. Average capillary pressure in the systemic circulation is 15 mm of Hg. Please remember, this capillary pressure is highest in the renal circulation. In the glomerular capillaries, it is 4 times this. It's 60 mm of Hg in the glomerular capillaries. So just correlate these things. 15 in the capillary beds everywhere, but in the renal circulation in the glomerular capillaries it is 4 times. Right. The next point is, why do we need this 15 mm of Hg? Because there is something called as tissue pressure. Look, capillary segment, capillaries are in the tissues and the tissue has a certain amount of pressure. The tissue pressure is about 6 to 7 mm of Hg. It's the tissue pressure. And if the capillaries need to have blood flow through them, then the pressure will have to be higher, greater than the 6 to 7 mm of Hg, right? So you see, by the end of the capillaries also the pressure is 10 mm of Hg, higher than the tissue pressure, and that's what drives the circulation through the capillaries. So that's one point which you must understand, why we need the capillary pressure. In fact, there was a question like this, and it's an interesting question. What will be the pressure in the dead? I mean, when the heart stops beating, what will be the pressure in the circulatory tree? Or what will be the blood pressure? And the options are 0 mm of Hg, 6 to 7 mm of Hg, or 20 mm of Hg, 36 mm of Hg. I'm sure your first thought is going towards 0 mm of Hg, because after death there would not be any pressure left in the circulation. Is that so? No, that's not the case. Actually, the pressure is 6 to 7 mm of Hg, because what happens is, when the left ventricle stops beating, I mean in the dead, heart is not beating, so left ventricle is not creating that pressure. What happens is that the blood mostly would accumulate in one segment of the circulation, mostly in the veins, and it will be redistributed, and the only pressure on the blood would be that of the tissues. So the column of blood and its pressure will equilibrate with the tissue pressure, and it will be about 6 to 7 mm of Hg. So that was one question which was asked previously. Now, if you know the concept like this, in this case, then you will be able to answer. The question can be put either directly, or they can give the garb of some kind of a problem based question or clinical based question, like a patient came to the emergency room and his heart has just stopped, so if you measure the pressure, how much will it be? Now this is a clinical mask given to that particular concept. Mask, or the approach is clinical, I meant. Okay, so that was one more point which I need to mention. And then the third point is, what is critical closing pressure? Critical closing pressure. Well, if I say capillary pressure, I've given one figure, 15 mm of Hg. Let's take the average as 15 to 20 mm of Hg, just to understand this particular point. Okay, because start the 30 at the start of the capillaries and end of the capillaries 10, so we can fairly say it's a 15 to 20 mm of Hg to understand this particular point. Critical closing pressure is that pressure in the arteries below which the vessels will close down and circulation will stop. The circulation stops if the pressure goes below that pressure in the arteries. The circulation stops and the vessels will close down. So that's called as critical closing pressure, and it is said to be about 20 mm of Hg of the arterial pressure. Why is that? That's because, look, when the arterial pressure is 100 mm of Hg, that time the capillary pressure is 15 to 20 mm of Hg, and the blood flow is possible through the capillaries. As I mentioned, there is a tissue pressure, so you need certain pressure in the capillaries. Now imagine if the pressure in the arteries itself, it goes below 20 mm of Hg. What will happen? This pressure gradient, 100 to 20 is a pressure gradient that is driving the blood. But if the arterial pressure itself drops below 20, what will happen? That pressure gradient will be completely dissipated and in fact even reversed. And then the blood flow cannot happen. There is no pressure in the circulation to drive the blood through the capillaries. So blood flow will stop and the vessels will close down. So that pressure is called as the critical closing pressure. These were some of the aspects related to the arterioles and the resistance vessels. Third type of vessel is capacitance vessels. Capacitance vessels means those vessels which can accommodate large quantities of blood. So veins are called as capacitance vessels because veins are low pressure vessels and they accommodate large quantities of blood. At any given point of time, more than half the blood is in the venous compartment. Yes, if you stop the circulation right now and see how much blood is present where, in which segment, you will find more than half the blood is in the venous compartment. Let's see. Veins accommodate 54% of the total blood volume at any given point of time. Arteries and arterioles 10 to 15% at any given point of time. Capillaries accommodate 5 to 8% of the total blood volume, and the remaining blood volume is present in the heart and lungs, in the chambers of the heart and in the pulmonary circulation. Pulmonary circulation can accommodate 15 to 18% of the total blood volume. So this is the distribution of the blood volume in different segments. But you can see that more than half is in the venous compartment, and they are called as capacitance vessels. Then next is the easier one, exchange vessels. You can say this. Exchange vessels are capillaries. There is exchange of materials between the capillary blood and the tissues, so they are called as exchange. These are normal. Now the last one is exceptional. So there was a question like this: which of the following is called as thoroughfare vessel? And I keep on saying this. For some MCQs, to understand them, you need to have a good English as well. So thoroughfare, if you understand what is a thoroughfare, you can answer this question. What are thoroughfare vessels? Thoroughfare is a broad to and fro way, passageway, which connects two main roads. That's called as a thoroughfare. So what do you think are thoroughfare vessels? AV anastomosis, arteriovenous anastomosis, they are called as thoroughfare vessels. So these are the functional types of blood vessels. Let's take one more short section that's related to the blood flow. Blood flow to various segments, various organs. First of all, velocity of blood flow. You know, velocity is different in different segments of circulation. Where do you think velocity will be highest? Aorta, arteries, capillaries, or veins? It's the aorta. Look, aorta, the velocity of the blood flow is 33 centimeters per second. Capillaries have a cross-sectional area which is 1,000 times that of the aorta, and therefore the velocity of blood flow in the capillaries is 1,000th of that of the aorta. It is 0.33 millimeters per second, 1,000th. That was the velocity of blood flow. Coming to blood flow in different organs. Greatest fraction of blood flow goes to which organ? This question was asked repeatedly in the previous exams. And liver, brain, kidney, muscle. So largest amount of blood flow goes to the liver, 25 to 27%. That's the hepatic blood flow. Second best is kidney, 22 to 25%. So these are the two largest fractions of blood flow, or two organs which receive greatest blood flow. Greatest blood flow per 100 gram of tissue per minute. Now this will be obvious. Let's write down blood flow per 100 gram of tissue per minute. If I'm talking about the organ, then the answer will be kidney. And it's very obvious, because see, kidney weighs only 1 to 2% of the total body weight, but it is taking almost 25% of the blood flow. So naturally, if you look at the blood flow per 100 gram of that tissue per minute, it will be very, very high in the case of kidney. 400 to 450 ml per 100 gram of tissue per minute. So if we are looking at an organ, kidney has no comparison. But if they are asking about any tissue in the body, not organ, any tissue in the body, then there is no match for carotid bodies. Carotid body has a massive blood flow. Check this out. 2000 ml per 100 gram of tissue per minute. That's the blood flow in the carotid body. I'm talking about the peripheral chemoreceptors, carotid body. So, massive blood flow. Carotid bodies have no match in that sense. Well, what is the significance of this high blood flow? The significance is that because of such a high blood flow, carotid bodies, they are always bathed in arterial blood. They are never exposed to venous blood. They will always receive a very high oxygen content because of this high blood flow. And the other thing that you must realize is that if there is anemic hypoxia, look, you know, hypoxia stimulates the peripheral chemoreceptors and thereby it stimulates the ventilation. But then, if it's an anemic hypoxia, we will describe it later in the respiratory system. Anemic hypoxia fails to stimulate the carotid bodies, fails to stimulate the peripheral chemoreceptors. You know why? Because carotid bodies have such a massive blood flow that even if there is anemia and therefore less oxygen content in the blood, but oxygen that is combined with hemoglobin will be less because hemoglobin itself is less in anemia, anemic hypoxia. But there is dissolved oxygen content, and because of the high blood flow, the dissolved oxygen reaching the carotid bodies is also good enough, you know, and they won't sense it as a hypoxic condition. So we will describe all this once again in the respiratory system. This is just contextual. Okay, measurement of blood flow to various organs. Look, blood flow to an organ and cardiac output in the entire body is measured by dye dilution technique or indicator dilution technique. So we can use various indicators. For example, for kidney, we use para-aminohippuric acid. For the liver, we use bromsulphthalin. Bromsulphthalin. I'll just write it down. It's one word, bromsulphthalin, to measure the hepatic blood flow. So these were the blood flows to various organs. The next is types of blood flow. Types of blood flow. Look, there are two types of blood flow. Normally, in all the blood vessels, there is the type of blood flow which is called as laminar blood flow, also called as streamline blood flow. How does it flow? I mean, what type of blood flow is it? If this is a blood vessel, the laminae of blood, they are flowing, and the laminae don't have the same velocity, all the laminae. You know, laminae are slipping, they slip past each other. See, it's like this. The lamina closest to the vessel wall has least velocity. Next lamina has greater velocity. Next lamina has even greater velocity. Central lamina has greatest velocity. So the laminae of blood, they are slipping over each other. And therefore, if you see the type of blood flow, this is how it flows normally in all blood vessels. And therefore, the blood flow has got a parabolic profile. It flows like a parabola. This is our normal blood flow in the vessels. The second type of blood flow is called as turbulent blood flow. When these laminae are disturbed and eddies are generated in the blood, eddy currents are generated in the blood, then it would be called as a turbulent blood flow. Now the only question is, when is it that the laminar blood flow gets converted into turbulent blood flow? I mean, the tendency of turbulence is determined by what? It will be determined by the number called as Reynolds number. So Reynolds number is an entity in physics that tells us about the tendency of turbulence in the blood flow. Turbulence created, eddy currents generated in the blood when Reynolds number will exceed a certain value. So please remember, when the Reynolds number is less than 2000, it's just a number, no units. So when Reynolds number is less than 2000, the blood flow is definitely laminar. And when Reynolds number is more than 3000, the blood flow is definitely turbulent. And between 2000 and 3000, it is transitional blood flow. Transition is happening. So that's Reynolds number and the tendency of turbulence. But Reynolds number itself depends on what? The Reynolds number is determined, or it depends on 4 factors. Reynolds number is proportional to VDP upon eta. Many books write eta like this. I know there is some other symbol for eta. Okay. So, 4 factors determine the Reynolds number. V is velocity. Velocity increases, Reynolds number will increase and turbulence will occur in the blood. D is diameter. P is density of blood or that fluid, and eta is viscosity. So Reynolds number is directly proportional to velocity, diameter and density. It's inversely proportional to the viscosity. Please remember that. Let me just add one point here. This is related to the blood flow itself. There is 4th power law of the radius or diameter. This question has been asked a number of times. There was angioplasty performed in a patient and the vessel diameter was doubled. How much will be increase in the blood flow? That's the question. The answer lies in this concept, 4th power law, that the blood flow changes by 4th power of the radius. So if I say radius was changed by a factor of 2, means it was doubled, blood flow will increase by 2 raised to 4. Okay, 16 times. So please remember this also as an additional factor. Since we have mentioned viscosity, let's also say something about the viscosity. Viscosity is measured in relative terms as well as absolute terms. See, what is viscosity? Viscosity is about the slipperiness of a fluid. Thick fluids have a more viscosity, thin fluids will have less viscosity. I mean, slipperiness will be more in the thinner fluids. I'll make a correction in that statement. Okay, viscosity is measured, when it is measured in absolute terms, poise and centipoise are the units for viscosity. And Otherwise, in relative terms, viscosities of the water is to plasma is to whole blood, they are 1:3:5. So viscosity of the whole blood is 5 as compared to water viscosity taken as 1. So that is about the viscosity. It talks about the shear stress between the laminae of the blood flow. After cardiac cycle, if there is one topic which is equally important, if not more, is the blood pressure. Clinically it is important. We have to measure the blood pressure clinically. Just I'll give you one example of how important is it as a technique of measurement of blood pressure. In my unit, if I ask 10 residents to record blood pressure on a patient, my observation was all 10 students had different readings on the same patient at the same point of time. Technique, method, one has to be a perfectionist in learning those methods. So understanding about the method, understanding about the curve, and all those things. So clinically very important topic. Academically, exam wise also equally important. Lots of questions have come in the past on this particular topic. So what we will discuss in this particular segment, introduction, determinants of arterial blood pressure. Well, yes, let's say at the outset, whenever now we mention blood pressure, it would essentially mean the arterial blood pressure, because it's the concept of perfusion pressure, in the sense that it's the arteries which distribute the blood up to the tissues, and that's possible only when they have a certain amount of pressure. The blood flows with a certain amount of pressure. So blood pressure would essentially mean the arterial blood pressure, arterial pressure. We'll see the determinants, we'll see the types, different types of blood pressure, measurement of the blood pressure and various fallacies or errors, and finally the regulation. Most important part will be the regulation, as we will see in our discussion. Let's start with the introduction. What is blood pressure? It's defined as the lateral pressure exerted by the moving column of blood on the vessel walls. So here is a vessel and here is a moving column of blood. The pressure that it exerts laterally is defined as the blood pressure. It has to be up to a certain range so that the tissues are perfused with enough blood. When the arterial blood flows with a certain amount of pressure, only then the capillaries will have adequate blood flow and tissues will have enough perfusion with blood. So that's the basic definition or understanding of blood pressure. Now, when we say pressure, it has 3 dimensions. This is just an additional thing that I want to add here, is that the pressure, the concept of pressure has 3 dimensions. What are those 3 dimensions? One is delta P. The other one is hydrostatic factor. And the third one is transmural pressure, pressure across the vessel wall. So these 3 dimensions make up or constitute the concept of blood pressure. Let me explain quickly. What is delta P? Blood flows in the circulation from high pressure to low pressure. And we have seen that at the start of circulation, that left ventricular peak pressure is 120 to 130 mm of Hg. Then arterial pressure is 100 mm of Hg, mean pressure. Then at the start of the arterioles, pressure is 80. Then end of the arterioles, pressure is 30. So in the capillaries, pressure is somewhere between 30 and 10. and then from 10 at the start of the veins to right side of the heart, 0. So that's a delta P, P1 minus P2, that drives the circulation, that drives the blood flow. So that's one dimension of the pressure, concept of pressure. Second is the hydrostatic factor. Gravity, the effect of gravity. You know, at the level of heart, the pressure is taken to be 0 mm of Hg. Particularly, what is the reference level for pressure measurement? If you have already not read about it, the level of tricuspid valve is said to be the reference level for pressure measurement. So pressure at the level of tricuspid valve is taken to be 0. Pressure below it means as you go towards the foot, gravity is acting on it. Hydrostatic factor means something like this. If this is a column of fluid and pressure at the surface is atmospheric pressure, or let's say 0, then as you go down into the fluid, because of the weight of that column of fluid, and weight means gravity involved, the pressure will go on increasing as you go down. So that's the hydrostatic factor, and therefore what happens is, as you go towards the foot, the pressure will go on increasing. It will be 90 mm of Hg more than what is present at the level of arm. And pressure above the tricuspid valve, or pressure in the head vessels, cerebral vessels, will be a negative pressure, sub-zero, minus. Remember this, and this is all the effect of hydrostatic factor. In fact, there is a negative pressure in the cranial cavity, and therefore, what is the application of this? During the cranial surgeries on the head neck region or cranial vault, when they open the cranial vault, they have to be very, very careful, because as soon as the vault is cracked or it's open a little bit, because of the negative pressure, the air can be sucked in, and there is a danger of air embolism. So this is apart from the topic, but just remember this hydrostatic factor. And the third dimension to the pressure is transmural pressure, pressure across the vessel wall. So this is a vessel wall, and pressure across the vessel wall is the transmural pressure. These are the three dimensions, and just remember this, that when the pressure in the blood flow will be higher, what has caused it? I mean, imagine vasoconstriction. The vessel has narrowed. Then the blood has to flow more forcefully in order to reach the tissues, and the blood pressure increases. So remember, at this stage, vasoconstriction, rise of pressure. Vasodilation, fall of pressure. Right, that was the introductory part. Let's start with the first aspect of blood pressure, and that's determinants of arterial blood pressure. And as I mentioned, I will be asking some of the MCQs. We will look at some of the MCQs. And with the changing pattern, it's always fixed in your mind that all the questions have to be problem solving type or clinical case based type. Okay, many of them will be like that, and even if you just have a normal question, it can be easily converted into a clinical one. For example, take this one, determinants of arterial blood pressure. The question related to this: a man is admitted in the hospital. So see, a clinical garb has been given to the question. So in this man, 50-year-old man, these are the findings. His cardiac output is 5 liters per minute, and his blood pressure is 90 mm of Hg. Let's take it as the mean arterial blood pressure. How much will be the peripheral resistance in this man? How much will be the peripheral resistance? And the options given are 1, 2, 4, 6. What are these values? I'm sure you must have started the calculation. 90 divided by, okay, let's just for the sake of ease of calculation, I'm changing the figure a little bit. Cardiac output was found to be 5.4 liters per minute. How is that? Yeah, okay. So now you must have started calculating 90 upon 5.4, or what is the answer coming? Okay, and the options given are 1 hour, 2 hour, 4 hour, 6 hour. Yeah, so what's your answer? Okay, in 5 minutes you yourself will give the correct answer. Let's start now. By Ohm's law, Q is equal to delta P upon R, right? Q is equal to delta P upon R. So delta P will be Q into R. Q is flow, and blood flow to all the tissues, all the organs, will be equal to cardiac output. So extending this equation from the Ohm's law, blood pressure is equal to, the Q is blood flow or cardiac output, and resistance, R is resistance, so peripheral resistance. So these two are the determinants of arterial blood pressure. It is equal to cardiac output into total peripheral resistance, TPR, the total peripheral resistance. So one factor related to the heart, that is cardiac output, the other factor related to the blood vessels, that is total peripheral resistance. And as I mentioned already, vasoconstriction will increase the resistance and increase the blood pressure. Right, these are the determinants. Let's come to the question that we had. Q is equal to delta P upon R. So that means R is equal to delta P upon Q. Okay, or R is equal to pressure upon Q. So we are now calculating the resistance part. Peripheral resistance was asked. Pressure is in mm of Hg, and I'm sure you were calculating 90 divided by 5.4 and the answer was not coming. Why was that? That's because the units are not matching. Mm of Hg is one unit, then liters per minute is not the matching unit. The matching unit will be ml per second. Okay, so let me now define the peripheral resistance. Peripheral resistance is measured in terms of PRUs. PRU, peripheral resistance units, or simply it's called R units. And 1 R is equal to 1 mm of Hg when blood flow at the root of the aorta is 1 ml per second. Okay, so blood flow and cardiac output should be expressed in terms of ml per second. Whereas when I mentioned the question, it was given as liters per minute. So here is one suggestion. Whenever you are sure of the formula and still the answer is not coming up, always look at the units carefully. Sometimes units are not matching and therefore there is a problem. So that's one good suggestion at this point. Okay, so 1 hour is equal to 1 mm of Hg per ml per second. That is equal to 1 hour or 1 PRU. Now in this case, mm of Hg, blood pressure was given 90 mm of Hg. And blood flow was 5.4 liters per minute. 5.4 liters per minute has to be converted into per second, ml per second. So 5.4 liters per 60 seconds. 5400 ml per 60 seconds. What is it? 90. Yes, 5.4 liters per minute is same as 90 ml per second. Yes, I did it just now. So 90 mm of Hg upon 90 ml per second, the blood flow or the cardiac output. The answer was 1 hour or 1 PRU, peripheral resistance unit. That was the first part, the determinants of arterial blood pressure. Second, let's now see the types of blood pressure. There are two types which exist in the body and two are calculated. So in all there are 4 types of blood pressure. 2 exist in the body and from those 2 the other 2 are calculated. Right, and the question which was asked once is, stroke volume is determined by what pressure, or what is the best determinant of stroke volume out of the given options? And the options are systolic blood pressure, diastolic blood pressure, pulse pressure or mean arterial pressure. You want to answer that? The answer is pulse pressure. Yes. Look, pulse pressure is the difference between systolic and diastolic. Let's see the types and then answer this question. Okay, 2 types are systolic and diastolic blood pressures. So, systolic BP, the highest pressure in the circulation when heart goes in systole. That's called as systolic blood pressure. And it indicates what? It indicates force of contraction of the heart. Force of contraction of the heart. Second, diastolic blood pressure. Diastolic blood pressure is the lowest pressure in the vessels, lowest pressure in the circulation when the heart goes in diastole. So, by the end of the diastole, there would be the lowest pressure in the vessels and that's called as diastolic blood pressure. What does it indicate? It indicates peripheral resistance. Diastolic blood pressure is the one in which heart is not ejecting out, heart is not in systole. So that time the resistance on the blood vessels, that will determine how the blood is flowing with how much pressure. One more dimension should be added here, and that is about the peripheral resistance. Look, when we say total peripheral resistance, it is just the addition of the resistances in different vascular beds, in different organs. Okay. But which tissue or organ is the greatest contributor to the peripheral resistance? Whenever I ask this question, many students answer as arterioles just because I have mentioned at the start, we have seen this, that arterioles are the resistance vessels, they contribute to the resistance. No, that was different. That is resistance for the blood flow. That is a segment of circulation. What I am asking is here is which vascular bed, which organ system offers greatest resistance to the blood flow. Please note it down properly. We will need this information in exercise, skeletal muscle exercise, that skeletal muscle contributes maximally to the peripheral resistance. I mean, more than 50%, more than half of the total peripheral resistance is contributed by the skeletal muscle alone. And why is that? Very obvious. Look, skeletal muscle is a contractile tissue, and as it contracts, skeletal muscle is contracting all the time, so it compresses the vessels within the muscle. Within its own structure, there are blood vessels which will be compressed when the skeletal muscle contracts, and that compression, that constriction, that narrowing will contribute to the peripheral resistance. So these two things you must remember when we discuss the exercise, cardiovascular physiology in exercise. I will be asking you these things again. Who is the greatest contributor to the peripheral resistance? Skeletal muscle. And peripheral resistance is indicated by which type of blood pressure? Diastolic blood pressure. Okay, let me just complete it here. After the skeletal muscle, the next circulation or the part that contributes is the cutaneous circulation. Cutaneous circulation contributes almost 30% to the peripheral resistance. Why? It's because the cutaneous blood vessels, they often constrict all the time because of the ambient temperatures. And as they constrict, there will be the resistance to the blood flow. So please remember, two organ systems which contribute maximally are skeletal muscle followed by cutaneous circulation. Alright, so we've seen two types of pressures which exist in the body. Now we will see the two which are calculated from these two. So next is pulse pressure. Pulse pressure is the difference between systolic blood pressure and the diastolic blood pressure. Systolic BP minus the diastolic BP is the pulse pressure. The difference between the two. And it is indicative of what? Pulse pressure indicates stroke volume. It indicates the stroke volume. Why is that? Look, here goes the diastole in the ventricle. The blood pressure goes to its lowest. Now with the next systole, the ventricle, the heart is going to contract and the pressure is going to rise. So from diastolic pressure, the rise of pressure up to the systolic blood pressure. And the difference between the two is the pulse pressure. Yes, how much will it rise in the systole? That difference is the pulse pressure. And what is happening during that period? The blood is being ejected out as a stroke volume. So stroke volume is indicated by the pulse pressure, or pulse pressure is the indicator of the stroke volume. And the fourth one, okay, just for the time being, remember this much, two things. Systolic blood pressure to diastolic blood pressure to pulse pressure, they are generally in a ratio of 3:2:1. That's one point. For example, if systolic blood pressure is 120, diastolic blood pressure is 80, then the difference between the two, the pulse pressure, will be 40, and therefore they are in a ratio of 3:2:1. That's one point. And second is, remember the formula in a different way. Diastolic blood pressure plus pulse pressure is equal to systolic blood pressure. Please remember it for the time being. I mean, the difference between the systolic and diastolic pressures is the pulse pressure, right? So diastolic blood pressure plus the pulse pressure is equal to the systolic blood pressure. Okay, simple arithmetic, but remember it for the time being. The last pressure is mean arterial pressure. Mean arterial pressure. What is the formula? Let's first write down the formula. The formula is mean arterial pressure is equal to diastolic blood pressure plus 1/3 of pulse pressure. Diastolic blood pressure plus 1/3 of pulse pressure. Why is such a convoluted formula for this mean arterial pressure? Okay, before that, let me just say this as well. What does it indicate? It indicates the average pressure in the circulation. Average pressure in the circulation. Right? Now let's figure out why such a different formula. Look, average pressure in the circulation will be the average of systolic and diastolic pressures. There are only two pressures in the circulation, systolic and diastolic. So average pressure in the circulation will be average of systolic and diastolic pressures. Right? For the time being, let's take those figures. Systolic is 120, diastolic is 80. How do we calculate this average? How do we calculate mean or average of two figures? We can take systolic plus diastolic upon 2, right? So 120 plus 80 upon 2, that is 200 upon 2, and that will be 100 mm of Hg. The arithmetic average of these two means 120 and 80, systolic and diastolic, that would be 100 mm of Hg, isn't it? How did we calculate that? Systolic plus diastolic upon 2, that gives us the average. I'm trying to explain why this formula is being implemented. Okay, right. So diastolic is 80 mm of Hg, systolic is 120 mm of Hg, and what is the mean, arithmetic mean? How do you calculate that arithmetic mean? Look, first of all, arithmetic mean, the mean or average is 100, as we saw just now, and the calculation was 120 plus 80 upon 2, that's 200 upon 2, and that's 100. Okay, how do you reach this 100? 100 is the exact midpoint. When we say mean or average, it's the exact equidistant between 120 and 80. It's exact midpoint of the systolic and diastolic blood pressures, the arithmetic mean. Okay, and how do you reach this 100? Look, I told you some time back, diastolic BP plus pulse pressure is equal to systolic BP, isn't it? 80 plus 40, 80 plus 40, you reach systolic blood pressure. Now, if you have to reach the halfway mark, exact equidistant between the two, then diastolic BP plus half of pulse pressure. Pulse pressure is 40, If you add half of that in the diastolic blood pressure, see here is the diastolic blood pressure, add half of the pulse pressure into the diastolic BP, so 80 plus 20, you will reach 100, you will reach exact halfway mark, isn't it? You add full pulse pressure, you reach there. You add half of pulse pressure in the diastolic blood pressure and you reach halfway mark, obviously, isn't it? Quite easy to understand. Okay, so arithmetic average, that was 100, was calculated like this: diastolic BP plus half of pulse pressure. What is our formula saying? Come on. What was the formula for mean arterial pressure? Diastolic BP plus 1/3 of pulse pressure. Not the half of pulse pressure, 1/3 of pulse pressure. Now, why is that? Let's understand from these figures. Diastolic BP is 80 mm of Hg and pulse pressure is 40 mm of Hg. Now, for the real formula, we are not adding half of pulse pressure, we are adding only 1/3 of pulse pressure. 1/3 of 40 is let's say 13. So 80 plus 13, you will reach 93. So now there will be some clarity. Systolic BP and diastolic BP 120 and 80. We are saying average pressure in the circulation, that is average of systolic and diastolic blood pressures. The arithmetic average was 100, arithmetic mean. But we used this formula and we added only 1/3 of pulse pressure into the diastolic blood pressure, so we are reaching 93. That's the average pressure in the circulation or average of systolic and diastolic blood pressures. Now my question is, why? Look, our formula is saying, and mark these words now, our formula is saying that the mean arterial pressure is not the exact equidistant between the systolic and diastolic blood pressure. Mean arterial pressure is not the arithmetic mean, it's not exact halfway mark, but it is slightly closer to the diastolic blood pressure. 100 would have been equidistant, arithmetic average, but our formula is saying that mean arterial pressure is slightly closer to the diastolic blood pressure. Let me write it. Mean arterial pressure is closer to the diastolic blood pressure. The average pressure in the circulation is slightly closer to the diastolic blood pressure because that's the most important statement. I mean, I did all this to make you understand the last statement, because diastole is of longer duration in the cardiac cycle. That's the reason. In a cardiac cycle, systole and diastole are not of the same duration. Diastole occurs for longer duration and therefore average pressure in the circulation is slightly closer to the diastolic blood pressure. I mean, imagine, normally in a cardiac cycle, systole is for 0.3 seconds, diastole is for 0.5 seconds. If the systole and diastole were for 0.4 seconds each, then the average pressure would be 100. I mean, the exact equidistant, because their durations are same, systole and diastole durations. But that's not the case. So this I wanted to explain regarding that formula for mean arterial pressure. Diastole is for longer duration in the cardiac cycle and therefore the average pressure in the circulation is slightly closer to the diastolic blood pressure rather than being the exact arithmetic mean of systolic and diastolic blood pressures. Alright, so these were the types of blood pressure. The third thing or third dimension of our discussion is measurement of the arterial blood pressure. Measurement of the blood pressure. what can be the question in this? Okay, problem based question. A patient is admitted in the ICU and his blood pressure is being monitored continuously and simultaneously by an intravascular catheter and the sphygmomanometry. All right, the patient's blood pressure is being monitored continuously by the intravascular catheter and the sphygmomanometry cuff. Both are being done simultaneously. What will be your recordings? And the options are: sphygmomanometry will give a higher pressure as compared to the intravascular catheter. Sphygmomanometry and intravascular catheter will give the same blood pressures. So look, intravascular catheter connected to the manometer. So both pressures will be same, or sphygmomanometry will give you the lower pressure as compared to the intravascular catheter pressure measurement, direct pressure measurement, or depends on various factors. So what's your answer? Sphygmomanometry will give a same pressure, higher. Okay, it will be giving us a higher pressure as compared to the directly measured intravascular pressure. Okay, why? We will see that just now. Okay, now first of all, sphygmomanometry is the name of the procedure, sphygmomanometer, and it has a Rivarocchi cuff, the Italian name after which the cuff is named. It's called as Rivarocchi cuff, the BP cuff. Right. First, there will be a palpatory method. In the palpatory method, we get only systolic blood pressure because we are palpating the pulse. Okay, and a pulse comes only with every systole. So we got only one indicator, and that is the systole in the heart, because with systole the pulse is coming, which we feel in the palpatory method. And the second point is, well, I'm not going to spend much time on actual method, how you perform and all. You will have done it already. But I'll discuss the theoretical part. In palpatory method, what is the fallacy in the palpatory method? In the palpatory method, we will get a lower systolic pressure than the actual one. Yes, the difference will be slight, but nevertheless, it's a theoretical or hypothetical difference, one may say, but it's there definitely. Slightly lower systolic blood pressure. Why? Look, we apply the BP cuff to the arm and the pulse is palpated at the wrist. The pulse is being palpated at the wrist, radial artery. Okay, so let's say the pressure in the vessel, systolic BP, is 120 mm of Hg. Okay, we increase the cuff pressure, take it up to let's say 150 mm of Hg, and start lowering it. Right now the vessel is obliterated completely. You are not getting any pulse there. The moment cuff pressure reaches 120 and still lowering, now the cuff cannot obliterate the vessel during systole at least, because cuff pressure is now, let's say, 120, 119, and systolic BP is 120. So now the pulse will reappear, and you can, the moment you feel the pulse, look at the manometer and that's the systolic blood pressure. But the problem is, cuff pressure reached the systolic BP in the artery, and the artery opens up now with systole, and pulse reappears again. So far it was obliterated completely. Now it reappears for the first time. It reappeared over here in the brachial artery, and it will travel to the radial artery where we will feel it. Okay, the cuff pressure reached the systolic pressure in the arm over here in the brachial artery, and then that pulse which appeared has traveled to the radial artery where we felt it. What happens during this time? We are lowering the mercury manometer continuously. So this lapse of time, whatever half second or less, the mercury manometer will go down slightly. You understand this? We feel the pulse at the wrist and we look at the mercury manometer. But actually the cuff had reached the systolic pressure of the vessel just before that, over here in the brachial artery. And there was a time lapse from this to the radial artery. Due to that milliseconds time lapse, it's assumed that mercury manometer went down a little bit, and then you looked at it when you felt the pulse at the wrist. So you get slightly lower pressure than what is actually present in the brachial artery. Right. Next, auscultatory method. What are the various fallacies in the auscultatory method? First of all, let's answer that question also. We are measuring the blood pressure by sphygmomanometry and directly measured intravascular pressure. There was a catheter introduced, and we will directly measure the pressure from the vessel. So how does it compare? And I had given the answer. We saw the answer that that is sphygmomanometry gives slightly higher pressure as compared to the directly measured intravascular pressure. Now why is that? Look, artery is deep within. Okay, here is a brachial artery. We have inserted a catheter and it's connected to the manometer. So that's okay. I mean, that gives you, let's say, direct pressure measurement from the intravascular catheter. The pressure is, let's say, 120 mm of Hg. And then what is the principle of sphygmomanometry? The Riva-Rocchi curve. Balancing of pressure between the cuff and the artery. Right? What I'm trying to say is, we will raise the pressure in the BP cuff. And what is the principle? Look, it's a principle of physics. Let's say pressure in the artery is 120 mm of Hg. So when the pressure just outside the artery becomes 120 or just above 120, then the vessel will be completely occluded. Okay, that's the principle on which we perform the palpatory method, auscultatory method. We raise the pressure in the cuff and then we start lowering it, and because the cuff pressure is greater than the pressure in the vessel, therefore vessel gets completely occluded. And the moment cuff pressure reaches the systolic pressure in the vessel, or whatever pressure we are recording, now the vessel will open up, isn't it? That is our principle. So if we have to occlude this artery completely, the pressure just outside the artery will have to be 120 or more than like 121, let's say. But for the pressure just outside the artery to be 120, cuff pressure will have to be about 126. You know why? Because some amount of cuff pressure gets dissipated in the intervening tissue. I mean, when the cuff pressure is 126, out of that the 6 mm of Hg, look, artery is deep inside and cuff is on the outside. So this cuff pressure, as it reaches out just outside the artery, some of the cuff pressure will get dissipated. Let's say 6 mm of Hg, and that means only 120 will reach the artery and will occlude the artery. So when the actual pressure in the artery is 120, the occlusion pressure by the cuff that we get is 126, and therefore by sphygmomanometry we get a slightly higher pressure as compared to directly measured intravascular pressure. Funny enough is that there is exactly opposite hypothesis also, that sphygmomanometry will actually give you a lower pressure than the directly measured intravascular pressure. The opposite hypothesis says that there is something called as tissue pressure. We have done this in the circulation, in the discussion for circulation, that there is something called as tissue pressure, and that tissue pressure is about 6 to 7 mm of Hg. So that opposite hypothesis says that this tissue between the skin and the artery, that tissue will exert 6 to 7 mm of Hg on the artery itself. That means if the arterial pressure is 120 mm of Hg, then to occlude this artery completely, we will have to apply only 114 mm of Hg. The 6 will be exerted by that tissue between the cuff and the artery. 114 plus 6, 120 will reach the artery and occlude the artery. So this is exactly opposite. Anyways, tissues do not exert the pressure on the arteries like that. Arteries are high pressure vessels, tissues cannot compress them, and therefore first hypothesis is more accurate, that if you compare the two pressures, means two methods, sphygmomanometry will give you a higher pressure compared to the directly measured intravascular pressure by the catheter connected to the manometer. Okay, so let's see the auscultatory method. What is the basis for auscultatory method? Let's say the pressure in the vessel is 120 mm of Hg, and please, for the time being, keep all this hypothesis aside. Okay, don't bring this hypothesis or that palpatory method hypothesis over here. It's not hypothesis. What I'm saying is, don't bring these dimensions into the discussion right now. Think about it independently. This pressure in the vessel is 120 systolic, 80 diastolic. We apply the BP cuff and increase the pressure. Now when pressure is raised up to 150 mm of Hg, the artery is completely occluded. Okay, you know, before we applied the cuff, just if you put the stethoscope over the brachial artery, will you hear any sounds? No, because the blood flow was laminar, and laminar blood flow does not produce any sounds. The turbulent blood flow produces sound. Let me just tell you once again, as a just as a quick recall, we have done this in the circulation segment, that there are two types of blood flow. Laminar blood flow, when Reynolds number is less than 2000 and it does not produce any sounds, and turbulent blood flow when Reynolds number exceeds 3000, more than 3000, and that produces sounds. Okay, so if you put the stethoscope right now over the brachial artery, we will not hear any sounds. It's a laminar flow. But then you apply the cuff, raise the pressure up to 150 mm of Hg and start lowering it. What will happen? The moment cuff pressure reaches 120 mm of Hg, please don't take that dimension right now. Keep that aside. I'm just trying to explain the auscultatory method. The moment cuff pressure reaches 120, now the artery will open up, and now the blood flow will happen with turbulence. okay, to the periphery. We have put the stethoscope over here and we will hear the sound, which is called as Korotkov sound. So we will get the sound tuck, with systole, and with diastole no sound, okay, because your cuff pressure is 120, 119, 118, 117. That means it is lower than the systolic pressure in the vessel, but it is still higher than the diastolic pressure in the vessel. Diastolic is 80, no? And you are in the range of 118, 117, 116, like that. So what will happen now? This Korotkov sounds will come intermittently. Tuck, gap, tuck, gap, tuck, gap, tuck, 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 and there is a gap between two sounds. Because with systole, the flow comes, and the flow comes with turbulence. And with diastole, no blood flow because vessel will be occluded. First three phases of the Korotkov sounds are like this: sound, then gap during diastole, then again with systole, next sound. Fourth phase is the sound gets muffled, and fifth phase is disappearance of sound. First three phases, as I mentioned just now, they were intermittently coming sound, and then muffled sound and disappearance. So which one should correlate well? Fourth phase of the Korotkov sounds or fifth phase? Look, disappearance of sound is most easily recognized, and therefore fifth phase is taken universally as the diastolic blood pressure. Okay, but try to understand. First three phases where intermittent sounds, means tuck gap sound during systole, then no sound during diastole. What is muffling of sound? Muffled means a continuous sound comes now. Continuous sound means what? Means there is a sound during systole as well as diastole. Why there is a sound during diastole? Because your cuff pressure has reached the diastolic pressure of the vessel. That's why now the flow also is coming with diastole. So far there was only blood flow during systole, but no flow during diastole for the first three phases, and therefore there was no sound during diastole, and the sounds were like tuck, gap. That gap was diastole in the vessel, diastolic pressure in the vessel, so no blood flow. Continuous sound, muffling sound means the sound is also during diastole. Why? Because there is flow during diastole. And why is that? That's because your cuff pressure has reached the diastolic pressure in the artery, and therefore artery is no more occluded even during diastole. The first three phases were where that the artery was opening up during systole and occluded during diastole. Again open during systole, occluded during diastole. But now that, so muffled, the phase 4 should correlate well with the diastolic blood pressure. But everybody cannot denote the muffling correctly. I mean, muffling cannot be noted very accurately by all the people, and therefore there will be discrepancies in noting the blood pressures, and therefore we take disappearance of sound as the diastolic blood pressure, but actually it should be muffling. You know, in fact, disappearance of sound means what? Disappearance of sound means that the blood flow again becomes laminar. As I told you, it's the blood flow which decides whether the sound will be there or not. Disappearance of sound means the blood flow again has become laminar. So far it was turbulent because the blood flow was going through a narrowed lumen of the vessel. So muffled sound means diastolic blood pressure has reached. So continuous sound is there. And disappearance means now the blood flow becomes laminar again. Okay, well, normally the difference between fourth phase and fifth phase is not much. It's less than 5 mm of Hg, so it's not going to make a great deal of difference. But under the conditions of high turbulence, under the conditions where there is high turbulence in the blood flow, what will happen? The difference between fourth phase and fifth phase will be much higher. You know, the difference can be as high as 40 mm of Hg. Means muffled sound and then 40 mm of Hg, and then the disappearance of sound. So a big difference between phase 4 and phase 5. In that case, there will be a discrepancy. Then you are likely to get a falsely low diastolic blood pressure, because you are taking disappearance of sound as the diastolic blood pressure, but actually the cuff pressure had reached diastolic blood pressure already when there was muffling of sound started. Phase 4 had started, but you are taking phase 5, that means lower point, and therefore you will get. So therefore remember, if there is a question that auscultatory method, what is the fallacy in the auscultatory method? What error, possible error can happen? Well, falsely low diastolic blood pressure can be the option given, and that will be the answer. So, but remember, that is more likely when there is a high turbulence in the blood flow, because then that murmurish sound or muffling sound will be there for a long time, and then it will disappear. Okay, so that was one more fallacy related to the recording of blood pressure. Next point is coming back to this comparison between sphygmomanometry and directly measured intravascular pressure. There was a question. We've already seen that the BP cuff, the sphygmomanometry gives you a higher pressure than the directly measured intravascular pressure. Okay. What will happen in the condition of obesity? Come on, now you should be able to answer. In the condition of obesity, even higher pressure by sphygmomanometry compared to the directly measured intravascular pressure. Why? Because obesity means more tissue mass between the BP cuff and the brachial artery. And more tissue mass means more dissipation of pressure, isn't it? After all, what was our funda when we said sphygmomanometry gives you a higher pressure? The funda was dissipation of cuff pressure between the arm, means skin, and the brachial artery. There is a tissue in between the cuff and the brachial artery, and some amount of cuff pressure gets dissipated as it reaches the brachial artery, and therefore we have got to apply more pressure in the cuff in order to occlude the artery, just occlude the artery. So in obesity, more tissue mass, that means greater dissipation of cuff pressure. So in order to occlude this brachial artery, which is having a pressure of 120 mm of Hg, you might have to apply 130 mm of Hg in the cuff, isn't it? So even higher pressure will be recorded in the condition of obesity. In the condition of atherosclerosis, again the same thing. If there is an atherosclerosis, arterial walls are thickened. There are cholesterol crystals, thickened irregular arterial walls, and therefore you will need an extra cuff pressure to occlude that artery completely. So again, falsely high pressure can get recorded in the condition of atherosclerosis. Then last one, what will happen with if you use a small cuff? By mistake, your cuff width is smaller than what it should be. What will happen? It will give a falsely high blood pressure. So in all these conditions, there will be a falsely high blood pressure, falsely higher pressure will be measured. Now, why in small cuff that is likely to happen? Because, remember this forever now, a small cuff tends to occlude the brachial artery incompletely. Smaller cuff tends to occlude the brachial artery incompletely, and therefore in order to occlude the artery completely, you need to raise the pressure in the cuff further. Then only it will occlude the artery completely. and therefore you are likely to get a erroneously higher blood pressure as compared to the actual pressure. Okay, small cuff is likely to give you this error, higher pressure measured by the sphygmomanometry. And the last one is the auscultatory gap. What will happen if there is an auscultatory gap or silent gap? Silent gap will give you low systolic and normal diastolic blood pressure. Low systolic and normal diastolic blood pressure. Now, why is that? Let's first try to understand. Suppose there is a person with a blood pressure of 200 by 100. Let's take some hypothetical figures. So, what do you expect to happen? At 200, first Korotkov sound should appear, then the sounds should continue to appear, and finally they disappear at 100. So you take these readings. Now, a person, atherosclerotic person, is having a silent gap or auscultatory gap. Means what? First sound appears at 200, then sound suddenly disappears at 170, again reappears at 140, and finally disappears at 100. So this gap, while you were lowering the pressure, that's called as silent gap or auscultatory gap. Means sounds disappear in this. They will again reappear and finally disappear. Now suppose suppose you are not aware of this, and then let me tell you, this is the reason why we first check the blood pressure by palpatory method, because that gives you the idea of a systolic blood pressure, isn't it? And then this error can be avoided. Silent gap and its error can be avoided. Always measure. You will know the true systolic pressure, at least the rough idea about it, by first checking the BP by palpatory method. Okay. Well, but we are not talking about the auscultatory method and silent gap. So avoids silent gap by, as I said, by first checking the BP by palpatory method. But suppose you did not do it. Suppose you did not check the blood pressure by palpatory method. You straight went for auscultatory method, and in this individual, and you are not aware of the systolic blood pressure in this person, and you raise the pressure in the cuff only up to 160 mm of Hg. Check that. You are in a silent gap. So when you start lowering the pressure, cuff pressure, first sound will appear at 140 and the sound will disappear at 100. So you will note down his blood pressure as 140 by 100, whereas actually it is 200 by 100. And therefore, in the conditions of auscultatory gap, you get a low systolic and normal diastolic blood pressure. That's an error. The reason for silent gap is not known. They say atherosclerosis, and therefore blood flow changing from turbulent to laminar to again turbulent. That's one possibility. Reynolds number going up and down. So that these were some of the aspects related to the measurement of blood pressure. In the next section, which is again a large one, we will discuss the regulation of blood pressure. But the point that I wanted you to understand was the Reynolds number, turbulence of blood flow, and production of sound. So as a revision, I'm just giving it out once again. We have done it already in the section of blood flow, but just as a revision, I'm doing it again here. The blood flow is of two types. First type of blood flow is laminar, also called as streamline blood flow, which is laminae of blood which are slipping past each other. So blood flows like this. And more important part is laminar blood flow is silent. It does not produce any sounds which can be heard through stethoscope. Right now in all our vessels there is laminar blood flow, and if you put the stethoscope you would not get any sound. But the other type is turbulent blood flow. When laminae get disturbed and eddy currents are generated, the blood flow becomes turbulent. And the turbulent blood flow produces sounds which can be heard through the stethoscope. And the last point is, when is it that the blood flow will become laminar or turbulent? It is determined by the Reynolds number. Reynolds number is just a number, it does not have any units. Reynolds number more than 3000, blood flow will be turbulent. Reynolds number less than 2000, the blood flow will be laminar. Why I revised it here? Already we have discussed it before. That's because you need to understand the funda related to the sounds, production of sound or absence of sound. All our discussion was based on that. Therefore, I revised it again. Sound will be produced and heard only if the blood flow is turbulent and Reynolds number is more than 3000. Otherwise, sound will not be heard. So that's why I revised it all over again, this particular part. Next section we will have regulation of blood pressure, which is another large section. So it will have baroreceptor reflex and all the amazing things related to the baroreflex, chemoreflex mechanism and other reflexes. We have discussed the vascular tree and the arrangement of blood vessels in the systemic circulation. Now those same features are applicable to the each individual organs, but there are some special characteristics found in different organs. So we have to discuss some regional circulations. We will discuss pulmonary circulation in lungs, renal circulation in the kidneys. So we will discuss them in those systems. Here, since we are discussing the CVS, we will see the coronary circulation. Some specific special features or characteristics of this circulation. First thing is that the heart has its own independent blood supply. Why is that? Because although entire body's blood comes into the heart chambers, but heart muscle and its entire thickness cannot derive oxygen and nutrients from this blood which has come into its own chambers, and therefore heart needs to have its own independent blood vessels and independent circulation. So that's what is called as the coronary circulation. Basically, at the root of the aorta, two coronary vessels emerge. So we will just quickly see the functional anatomy of the coronary circulation. From the root of the aorta, these two coronary vessels, right and left coronary arteries, they emerge and they run on the anterior wall of the heart. So we have right and left coronary arteries. The left coronary artery gives out a branch, circumflex artery, and then it descends down on the anterior wall of the heart. So this would then be called as left anterior descending coronary artery, and therefore on the anterior wall you will see a right coronary artery and the left one which has given out a branch, and then left anterior descending coronary artery. Many cardiologists have called this left anterior descending coronary artery as the widow's artery because it's most commonly involved in fatal myocardial infarctions causing sudden death, and of the male, predominantly it's seen in the males, this kind of phenomenon. So it has been called as widow's artery. So these three arteries then run to the edge of the heart, and then they will turn backward to then anastomose on the posterior wall of the heart. So they will finally make an anastomosis on the posterior wall of the heart, which is shown with the broken lines here. So these are the major vessels, and then their branches will run perpendicularly. The branches of these arteries, then the smaller branches, will penetrate the heart muscle in a perpendicular fashion, like this, and then there will be distribution of nutrients and oxygen to the myocardium. So that's basically a quick review of its functional anatomy. Let's now understand some special characteristics. First point, coronary blood flow is about 4 to 5% of the cardiac output, 225 to 250 ml per minute. Roughly, that's the coronary blood flow under normal basal conditions. Second point is that the coronary circulation shows auto-regulation of the blood flow. That is, it regulates its own blood supply, its own blood flow. Let me just quickly have a few words about this auto-regulation concept. Whenever a particular organ system needs extra blood flow, it is diverted from some other part of the body. So that other part will be deprived of some amount of blood supply for some time. But in the case of vital organs, brain, heart, kidney, they show this phenomenon of auto-regulation. Whenever there is a need, they can increase their own blood supply, and otherwise in a wide range of blood pressure, their blood flow remains constant. So that's called as auto-regulation of blood flow. And the most important regulator is adenosine. Adenosine is said to be an important vasodilator and the substance that's involved in auto-regulation of blood flow. For instance, when the heart rate increases, the myocardial oxygen demand will also increase. So it will need extra blood flow. What happens is, as the heart rate has increased, there is increased ATP breakdown in these myocardial cells. This will lead to formation of ADP, finally AMP, and then just the adenosine. Once this adenosine is formed, it will leak out of the cells, myocardial cells, and it will dilate the vessels locally. There will be dilation of the vessels so that the blood flow can be increased. That was the demand basically of the myocardial cells. Apart from that, of course, there are K plus ions, H plus ions. So these two also can increase the blood flow or regulate the blood flow to the myocardium. Third point, and an interesting one, an important one, that the heart receives its blood flow during diastole. Yes, all the other tissues in the body, they would receive their blood flow during systole, as the blood is ejected out by the left ventricle. The other organ systems, all of them, they receive the blood flow during systole, but heart itself receives the blood flow during diastole. Well, this is a generalized statement, but let's make a distinction in this as well. Let's understand that there are two types of blood vessels: the epicardial coronary vessels and the endocardial coronary vessels. Vessels in the outer wall, vessels in the inner wall. So what happens is, during systole, the heart contracts inward. The heart contracts in an inward fashion. And therefore what happens is, the outer two layers have a pressure on the innermost layer. And therefore the blood vessels in the innermost layer, the endocardium, they will be compressed during systole. But there will be blood flow in the epicardial vessels. No problem there. Now, when the heart goes in diastole, reverse will happen. As the heart goes in diastole, it expands in an outward fashion. So this time, what happens is, these endocardial vessels will open up and there will be a blood flow. But because it's expanding outward, those epicardial vessels in the outer wall, they will get compressed this time, and the blood flow will stop in those vessels. So therefore, please understand that there is a phasic blood flow in the heart, in the coronary circulation, and as I mentioned just now, epicardial coronary vessels, they will receive the blood flow during systole, and endocardial vessels, they will receive the blood flow during diastole. Coming to more functional characteristics, another important one, arteriovenous oxygen difference. You will need to concentrate on this particular characteristic. Arteriovenous oxygen difference is highest in the case of heart. Please remember, let's have a background. What is this arteriovenous oxygen difference? I have already made a mention of this in the respiratory system in the discussion of oxygen. So you can refer to that part again. Normally, the arterial blood carries 20 ml of oxygen in every 100 ml of blood. Every 100 ml of arterial blood carries 20 ml of oxygen. When it reaches tissues, now I am talking about the other tissues first. Under normal basal conditions, 5 ml is extracted by the tissues under basal conditions of metabolism. And it means 15 ml oxygen will go back in the venous blood. So, arteriovenous oxygen difference is 5 ml for other tissues in the body. 5 out of 20 is 25%. So that's the case with other tissues. In the case of heart, this difference is 75%. Arteriovenous oxygen difference is 75%, highest for any organ in the body. That means if the arterial blood is carrying 20 ml of oxygen in every 100 ml of blood, then myocardium will extract 15 out of that 20 ml, and 15 out of 20 is 75%, highest. So please remember, it's least in the kidney, 10 to 12%, then 25% for most of the organs, and 75% in the case of heart. And to extend this further, you may also understand that this is the problem in the case of heart. I mean, why we often encounter myocardial ischemia and infarction, coronary artery diseases. This is the problem. Why such a phenomenon is generally not seen in other organs, but in the case of heart. It's because all the other tissues have a good oxygen reserve, in the sense that they are only extracting 25% of the oxygen coming to them. So if the need increases, the other organs can extract more amount of oxygen, 10 ml, 15 ml. They have that kind of a reserve. Heart is already extracting 75% of the oxygen coming to it. And therefore, when the need increases, then the blood flow itself will have to increase, because it does not have the oxygen reserve. And if the blood flow does not increase proportionately, then the problems will start. I mean, infarction is because of that factor. And therefore, you see coronary artery diseases or myocardial ischemia and infarction is primarily because of this reason, poor oxygen reserve for the heart muscle. Next point is about the nutrition to the heart. Again, a very unique feature related to the heart. All the other organ systems in the body, they are primary users of glucose and carbohydrates. Heart is the exception. In the case of heart, it primarily utilizes fatty acids, lipids instead of carbohydrates. Another unique feature related to the myocardium. You know, almost 67% of the energy is derived from the free fatty acids. 67 to 70%, more than 2/3. And glucose and carbohydrate sources, hardly any. And 3% the other nutrients. So that's another important unique feature related to the coronary circulation or the myocardium. Now next, energy efficiency. Energy efficiency of the myocardium. What type of cardiac output is the economically the best one for the heart? Look, cardiac output is equal to stroke volume into heart rate. We know that already. So, best economy of the myocardium. And when I say economy of the myocardium means the ratio of work output per unit O2 consumed. Work output per unit O2 consumed. That ratio is been called as economy of an organ. Here we are talking about economy of the myocardium. So how much oxygen is consumed by the myocardium and how much work output is given. That ratio. Now best economy is when there is increased stroke volume and decreased heart rate. When the cardiac output is maintained with an increased stroke volume and a decreased heart rate. This is economically the best one. It will consume less oxygen and would produce a better work output. Then the second best is when there is a normal stroke volume and a normal heart rate. That's the second best economically. Now the bad economies. If there is a normal stroke volume or any stroke volume and there is an increased heart rate, now the myocardial economy will suffer. Why? The reason is increased heart rate increases the oxygen consumption proportionately. When there is an increased heart rate, there is an increase in oxygen consumption proportionately. And we are talking about the economy of the myocardium. So, if there is an increased oxygen consumption, that's in the denominator, what will be the end result? Economy of the myocardium will suffer. So, that's not a good economy. And finally, what is the worst kind of economy for the myocardium? Is that for any stroke volume and for any heart rate, if the cardiac output has to be maintained against an increased afterload, if the cardiac output is being maintained against an increased afterload, then it's economically the worst. The work output becomes less and a lot of oxygen is consumed. So this is a poor economy. That was about the economy of the myocardium. So these are some of the important characteristics related to the coronary circulation. And you know the applied physiology, the coronary artery diseases, myocardial ischemia and myocardial infarction. Basically, angina is one disease that you may have read. Why there is chest pain in angina? First of all, there is an imbalance between oxygen consumption and oxygen delivery. This is the primary cause for angina. Now what happens is, why there is this chest pain in angina? It's because since oxygen delivery is lacking, therefore in that region of the heart there is anaerobic metabolism, and this anaerobic metabolism will generate lactic acid. Now this lactic acid will leak out of the cells, myocardial cells, and it starts irritating the nerve endings in that region, and that results in pain. So these are some of the features of the coronary circulation and some applied clinical physiology. That was a short topic, just the important characteristics. So just remember these few points, that it shows autoregulation, then arteriovenous oxygen difference is highest in the body in the case of coronary circulation. It derives its nutrition mainly from the free fatty acids, which is again unique, and it receives blood flow mainly during diastole, again a unique feature. So these are some of the important characteristics.